This podcast is sponsored by Pfizer. At Pfizer, we believe collaboration is essential for advancing the treatment of chronic immunoinflammatory diseases. Through research and education, we remain dedicated to supporting the healthcare community to improve the lives of those impacted by rheumatic diseases. To find out more about our commitment, visit Pfizer.com. And don't miss our Innovation Theater at ACR Convergence, presented by Dr. Christina Charles Showman on October 26th at 2 p.m.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Sometimes in rheumatology, the biggest breakthroughs come not from discovering a brand new disease, but from finally paying attention to one that's been hiding in plain sight. Calcium Pyrophosphate Deposition Disease, or CPPD, is one of those. It's common, it's painful, it's everywhere in our clinics, and yet for decades it's lived in the shadow of gout. It's been misdiagnosed, undertreated, and frankly, under-researched. Today's guest, Professor Tristan Pascaert, has been quietly helping to change that. He's part of a new generation of researchers who are not only unpacking the genetic and molecular basis of CPPD, but also testing what actually helps our patients feel better, from short courses of steroids to biologics like tocilizumab and IL-1 blockade. In this conversation, we explore what's new and what's next, why CPPD might be the most common inflammatory arthritis after age 60, how CPPD overlaps with rheumatoid arthritis and osteoarthritis in ways that can confuse even the most seasoned clinician, and also what early studies of biologics are teaching us about the biology and the promise of this long-neglected disease. This episode is part of a special series of conversations airing during ACR Convergence 2025 in Chicago, where we're highlighting a few of the novel ideas being presented at this year's meeting. Professor Tristan Pascaert is a French clinician and researcher. He's the head of the rheumatology department of the Lille Catholic University Hospitals and professor of rheumatology at the Lille Catholic University Medical School. His research focuses on crystal-induced arthritis, including CPPD and gout. He led the first clinical trial performed in acute CPP crystal arthritis, the Colchicort trial, which we'll talk about today. He's also involved in the steering committee for the development of the 2023 ACR EULAR classification criteria for CPPD. Enjoy. Tristan, welcome to the show.
Hi, John.
So I'm really excited to talk about CPPD today. This is actually only the second time we've been discussing CPPD in this podcast. The first episode, which I highly recommend that everybody listen to, was with Dr. Sarah Tedeschi, talking a little bit about CPPD. And what we're going to be focusing on today is therapeutics. So how to manage patients with CPPD. And we're so fortunate to have you here, Tristan. You've done some work in this field and written about it, and super excited to speak with you. And I think a lot of us will benefit from your insights, because I find that, patients with CPPD, especially with chronic CPPD, are really difficult to treat. So let's start from the beginning. And what's your understanding of what CPPD is? Like, why do people get it and who's at risk?
Well, it's a very exciting question, and of course, biased because I'm really involved in researching on that disease. It's actually been quite recent, since many people are now looking into the disease, which has been quite neglected for the past decades, since its discovery almost 50 years ago now, a bit more actually than 50 years ago. And we are getting more and more interest because we are just understanding that it's probably the most common cause of inflammatory arthritis after 60 years,
Wow.
which is often misdiagnosed because basically, the disease is quite easy to recognize when it's the acute arthritis presentation. We used to call that pseudogout because basically it's looking like a gout flare, but just in different joints. They are caused by the presence of calcium pyrophosphate crystals, which basically do the same thing as urate crystals by triggering some big inflammatory response from every now and then. So for those, they're quite easy to recognize and they're easily diagnosed, usually in the hospital setting. But these crystals can also be responsible for some symptoms that are more chronic. So either it's about recurrent flares and they're very easily recognized, but they can also present with persistent arthritis, which is sometimes misdiagnosed for any other cause of inflammatory arthritis. So that's the challenge. Why people are getting it, that's a huge question right now. We just published last year, well, this year actually, the first paper on the genetic basis of having CPPD disease. And we are seeing that there are some genetic abnormalities in managing pyrophosphates, and eventually this ends up in creating those crystals. So this is where we're now in the understanding of why people are getting it, and we have so much more to know about it.
So, in addition to the genetics, I know that age is a big risk factor. In evaluating patients in your clinic that either have acute episodes of CPPD or more chronic CPPD, what's your typical workup?
Well, usually we look into some other causes of having those abnormal crystals that get to form, basically. So typically we look for primary hyperparathyroidism, which is a quite common cause of CPPD disease, and hemochromatosis. But often we just don't find anything really. It's idiopathic so far as we know. So usually it ends up negative. We measure magnesium levels because magnesium is involved in this balance between calcium crystal formation. And when you are lacking magnesium, it pushes your balance towards creating pyrophosphate calcium crystals. So that we measure, but otherwise, basically, it's always negative.
Yeah. And then since, you mentioned that there may be some genetics involved, why is it that older people get it and most young people don't get CPPD?
That's an excellent question. We don't really have an answer to that, really. Probably that the mechanism is quite long to let those crystals appear.
Hmm.
Basically, before the age of 60, it's pretty rare to see any of it on imaging of CPPD. But as the decades come by, you have more and more people, and most of the time asymptomatic people, that have what we call chondrocalcinosis, so evidence of CPPD on imaging. And while you almost never have it before the age of 60, it's from 25 to 50% of people after the age of 80. So something is happening
Hmm.
slowly later in life, probably genetic driven, but also other factors that we don't know of yet.
Great. And then, thinking about treatment, so it sounds like, a vast majority of people have chondrocalcinosis and don't necessarily have symptoms, so may not need treatment. But in thinking about treatment, like what are the outcomes that you want to achieve when thinking about managing CPPD?
Well, there are some outcomes that we are not able to reach at all yet, and some that we can. One of the outcomes that has been aimed at, and particularly by patients, is to, at some point, like in gout, get rid of the crystals. So that would be one of the biggest objectives, I think, in CPPD disease, but that we are not able to do that yet. It has been tried in the past, particularly with the use of probenecid, which is usually a treatment that's being used for gout, as it's uricosuric, but it's also an anion transporter inhibitor, which is preventing ATP to come out of cells, and this ATP will eventually become pyrophosphate, and that's one of the causes of this crystal formation. So this has been tried but didn't work out in people. It had worked out in vitro but not in people. The other drug that has been tried out was to supplement people with magnesium. As I said earlier, it's involved in this crystal formation, but it's a very old trial, more than 30 years old now, but didn't work out either. So far that sort of crucial outcome of getting rid of crystals like we have in gout, and we do that very easily in gout. We don't have it. So basically, everything else is about controlling inflammation and the consequences of inflammation. And so the outcomes that we are going to try to improve will be the decrease in tender joints, swollen joints, and also the improvement of the quality of life. Had been shocked a few years back when we did some work for the OMER Act, and we interviewed our patients to see what was important for them. And before those interviews, I hadn't measured how important the impact on their quality of life CPP disease is. And really, what they are asking for is just to come back to a normal life, which is just impossible when the disease is there. So probably half of the outcomes that has been decided as being core outcomes are about some quality of life and the general impression that patients have of how they are doing, how they're responding to treatments. It's a bit subjective, but it really what it's seeming to count for people.
Okay, that makes sense. You said that acute CPPD is sort of easy to recognize. Can you talk a little bit about how it typically presents and then discuss, what are the main ways that we think about treating acute CPPD?
So, yeah, acute CPPD is actually quite often encountered in hospital settings where often older people are hospitalized for sometimes other reasons than any joint problem. But during the course of the hospitalization, they develop an acute arthritis, which is the typical crystal acute arthritis, which sort of explodes in a few hours. There's this swollen joint, hot, red, and extremely painful, just like in gout. It's just that it's usually different joints that are being affected. The most typical ones are the knee, the wrists, and to a lesser extent, the ankles. Basically, any joint can be affected, but mainly it's those. And there's this very typical acute presentation, which we know as the crown dent syndrome, which is the inflammation of the longitudinal retroodontoidal ligament, which is basically between the first and second vertebrae. And it's like a very sudden and inflammatory neck pain. People just can't turn their heads on the sides with some elevated acute phase reactants. And this is very typical of CPPD disease. So these are the very common presentations. To have the diagnostic confirmation, what we do is typically put a needle in the joint that is being affected so that we can have some synovial fluid analysis under the microscope. And just like with the urate crystals, we can see the pyrophosphate calcium crystals under the microscope. They have a fairly typical appearance. And so you have the very clear diagnosis there. You're going to have some imaging where you can see some imaging evidence of CPPD if you can't put a needle in the joint you want to look at. And then you have usually quite easily the diagnosis. And in terms of treatments, we really have some conventional treatments that in theory can be used. So that's just like in acute flares in gout, that's colchicine, NSAIDs, and steroids. The differences from gout is that people are usually far older. In the clinical trial that we had in Colchicort, where we compared colchicine to steroids, the mean age in the trial was 88 years old. So
Oh my
it,
goodness.
it's really, yeah, an age that you probably want to avoid any use of NSAIDs. So even though in theory they're very efficient, we want to avoid that. So usually the battle is between colchicine and steroids. In the Colchicort trial, where we compared 1.5 milligram of colchicine on the first day and 1 milligram on the second, compared to 30 milligram of prednisone on day 1 and 2. Basically, the response was the same between the two groups in terms of pain VAS decrease. Around two-thirds of patients were doing really well on day 2, and they were quite equivalent. We did a post-hoc analysis that we just published recently that suggested that probably the flare resolution was more effective with prednisone. So we tend to favor prednisone over colchicine in the acute setting, particularly as colchicine can be responsible for diarrhea in around 20% of people. And in older people, having diarrhea can have many consequences. So we tend now to recommend to use prednisone 30 milligram for 2 days as a first line. And if for any reason you can't or you don't want to use prednisone, then colchicine works pretty well, and overall is safe to use it.
For this trial, did you come in thinking that colchicine would be superior or inferior, or you really were agnostic and had no idea which one would be more better?
More of an agnostic approach. We designed it as an equivalence trial, which ended up on the primary outcome to be the case. So, yeah.
Great. And I was also surprised that you recommend a 2-day prednisone course and not longer. I think at least for gout, often if you don't treat for long enough, the gout can recur. Are these patients also at risk of having disease recurrence if you just stop treatment for 2 days, or do you feel like 2 days is sufficient?
At first, we also used in our practice to use longer courses of treatments, but actually in acute crystal arthritis and in gout, we have primary outcomes on efficacy which are actually very close to the beginning of the course because we know how painful it is and how we want to be quickly efficient. So that's why we actually chose short courses, because we wanted people to be relieved of their pain very quickly. So yeah, in the back of our mind, we thought that maybe that would be too short. And we were, yeah, actually quite surprised to see that it was actually sufficiently efficient in really most patients in only 2 days. And we continued to follow the patients until day 8. And
Mm.
actually, they did not flare up after the treatment was stopped. So basically, yeah, for some patients, 2 days was not sufficient. We eventually had to do some steroid injection in the joint to really have the flare fully resolved. But in general, it was sufficient.
Amazing. And then, you brought it up, steroid injections versus systemic steroids. Are there times when you might favor one versus the other?
Well, the only situation where possibly colchicine could be a better choice seems to be with people with diabetes. It's not that there were any significant hyperglycemia in people in the Colchicol trial treated with prednisone, but in terms of response, when we looked at the efficacy data in the post-hoc analysis, it seemed that, yeah, people with diabetes, I don't really know why, but seemed to better respond to colchicine than to
Yeah.
prednisone. So apart from that situation, otherwise, I think prednisone is the best choice
Got
overall.
it. And what about intra-articular steroids?
Well, when it's a monoarticular arthritis, it's always a good choice. The problem is when you've got this acute arthritis, you always have in the back of your mind the septic infectious risk. And you know that also this septic arthritis can coexist with the crystal arthritis. So until you have the culture that says, okay, no germs, and you can just put the steroids you want in the joint, there's this sort of 2 to 3 days gap in between where you're not 100% sure what you are doing. And so that's why we designed the Colchicol trial this way. But indeed, once you've had this certainty that you don't have septic arthritis, it's particularly true for the knee when really the diagnosis can be a bit trickier. It's really useful and it really works well, actually, to have the joint injection.
Got it. But in those 2 to 3 days, so let's say you aspirate a joint, in those 2 to 3 days, I mean, you're still giving these patients prednisone.
Yeah, exactly.
Okay.
But
And I guess, if they had an infection, that also wouldn't be the best thing.
that wouldn't be the best thing, but really from experience, the disaster of seeing people with septic arthritis really having had an intraarticular injection with steroids is far worse than systemic steroids. So yeah,
Great.
took
Makes
that chance.
sense. And I guess you didn't have problems in this study that about complications from, septic arthritis
Nope,
in
none.
patients that were given steroids. Great. That's certainly reassuring because it's certainly one of the things we think about. And one of the things, I sometimes think about, to say, well, why don't we give colchicine because we're concerned, could they have an infected joint? Maybe wait for those, 24 to 48 hours to make sure that the cultures remain negative. But you said that was the easy thing, that the management of acute gout, and not so easy. But it sounds like, at least from your research, both colchicine and prednisone seem to be pretty effective. And I was surprised that very short courses of either one of them for just a couple of days, and maybe favoring prednisone for most patients, except for those with like uncontrolled diabetes that may do better on colchicine, paradoxically. Very good. So let's talk about CPPD. And, this is like, as you mentioned, diagnosing this is very challenging. I remember being referred a patient that had a diagnosis of like refractory rheumatoid arthritis. And the previous provider, I think, had done like a Vectra, like one of these, looking for like cytokines. And it was like through the roof, a lot, very inflammatory. But, if you get x rays of the hands, there was certainly chondrocalcinosis. And I thought that instead he had CPPD. When should we think about CPPD as causing, the chronic polyarthritis that you mentioned? When should that come into our minds?
I would say basically all the time in people over 60. I remember this really great work from Berlin, Germany, where they looked into their cohorts of people with rheumatoid arthritis, and particularly in seronegative RA, chondrocalcinosis was surprisingly frequent. And eventually they actually diagnosed CPPD disease in quite a lot of patients. So yeah, RA, particularly seronegative RA in older people, should ring a bell. One of the big tricks and very complicated situations are with polymyalgia rheumatica, because actually
Mm,
crystals can go into the acromoclavicular joint. And as you could expect, this causes some pain in the shoulders. And it gets tricky when people are treated like PMR, but eventually became cortico-resistant or cortico-dependent. And it's usually in those situations where we eventually give a diagnosis of CPPD disease. And finally, even more tricky, the situations in which you have some sort of weird OA, weird because of the localization of OA, particularly at the hands, where the MCP joints are a bit too much affected and even have OA without usual patterns of hand OA otherwise. So in those cases, yes, you need to think about it, and more than you would expect, you would eventually give that diagnosis.
You mentioned about chondrocalcinosis, so looking at the x-rays. How often do you do ultrasound or other methods to visualize the calcium crystals deposited in the joints? Like, is that also helpful? Because some patients may have CPPD, but they have actually RA, and some patients may have chondrocalcinosis, but have rheumatoid arthritis. And some patients may not have evidence of chondrocalcinosis, but actually have, CPPD in their joints.
Yeah, the imputability of the crystals we're seeing on radiographs and other imaging techniques is always very difficult to ascertain. I'm doing a lot of research on dual energy CT in gout first, and we used it in CPPD as well. So it provides with a really a higher sensitivity to find those crystals compared to plain X-rays, who
Hmm.
basically have a sensitivity between 50 and at best 70%.
Hmm.
And so you're missing a lot of people with authentic CPP crystal in their joints, but you're just not seeing them on conventional radiography. So that's my bias because I do a lot of research. I have access to CT scans easily, but in the clinical routine of most rheumatologists, ultrasound, if you're a bit trained, is really useful because the sensitivity is really high and comparable to actually CT. And it's really useful for rheumatologists who know how to use it for the diagnosis. And when we developed the ACR-EULAR classification criteria for CPPD disease, actually seeing crystals on imaging had a huge impact on having the diagnosis or not, particularly when several joints have CPPD, because you have to be a bit cautious when you're seeing CPPD on only one joint, because if you've had a trauma, some
Hmm.
meniscal intervention and so on, you can easily have as a healing process some calcium deposits there. But if you have in plenty of joints, it really raises the probability that these crystals are involved in some manner or the other in the symptoms you have. And actually in RA, people with RA and CPPD are experience usually more pain than people with
Hmm.
only RA, let's say. So anyway, you need to have this in mind, even if you're not sure they're fully responsible for the symptoms.
Hmm. So, in thinking about managing, what are the options and what's the evidence between, several of these medications? Because I think these are, as I mentioned before, some of the most difficult patients to treat because at least in my experience, is hard to get something that's like very effective for them.
Yeah, I agree. And also, the tricky part is that pretty much everything is off label. So, if you make the diagnosis, that's the first important part to treat
That's
people
hard.
properly. Yeah. Even though people can get some right treatments, even if they had the wrong diagnosis, because basically everything we know of treatments yet have been developed for other rheumatic diseases than CPPD. So, if you misdiagnose, you may be lucky. So we got a lot from gout because gout and CPPD share some inflammatory patterns and have some really pathophysiological responses that are quite similar. And so colchicine on the long term is one of the best options to try first, and particularly using it on well, in Europe, it's 1 milligram per day or zero point 0.5 that can be used. And when we looked at how people in Europe were doing in referral centers for crystal diseases, it was really basically their first line therapy for all patients. And from experience and from what we had in that study, I think somewhere close to 50% of patients really do better with colchicine. So it either reduces the frequency of flares when they're recurrent acute arthritis flares, or it reduces the overall pain and general impression of how the disease is doing, disease activity in patients. So really, I think that should be the first line in all cases.
And then, so just to confirm the doses, you said you're using 1 milligram, so
Yeah,
2.5 milligram pills in Europe, and we would use two of the zero point 0.6 milligrams.
exactly.
Do you do it once daily or in divided doses? Does it matter?
I don't think it matters much. It really depends on the habits of the
Okay.
physicians, I think. So far, we only have very old trials, and actually, it's only one old crossover trial of 10 patients who had nothing, and they counted the flares, and then they gave them for a year 1 milligram, and it reduced by two-thirds the number of flares over the next year. But so far, it's
Pretty good.
only that. Hopefully, we'll have more data to come in the next years. So Sarah Tedeschi, that from Boston, that you had last year, is leading a trial on colchicine versus placebo, and I just this week got funded also a trial to do in France. Same thing, colchicine versus placebo in chronic
Amazing.
symptoms of CPPD. So we'll have hopefully the actual demonstration that it works. So that's the first line. I think it's quite accepted by everyone. And then it really depends on where you are. There's a big debate about the efficacy of methotrexate in CPPD. There's only one small crossover trial that has been tried 10 years ago, but the primary outcome was the DAS 44, and basically it was probably not an appropriate measure, and the trial ended up negative. In the experience of what we had in Europe, many physicians are using it. The persistent is good, but it's quite often combined with other treatments, so it's really difficult to say whether
Mm.
methotrexate is useful or not. I tend to try it in people with persistent arthritis that is sort of RA-like and see how it does, and sometimes it seems to work out. And the
Do
other
you
drug,
have do you push the dose as much as you would for RA or
because people are usually in the chronic phenotypes, people are a bit younger than the acute phenotype I was mentioning earlier, but still they are getting older, and usually the renal function is
Mm.
not that good. And so we're quite cautious with methotrexate, and I try not to exceed 15 milligrams per week. Yeah, I don't
Okay.
go further from that.
Okay, so we
There's
have colchicine that seems to be sort of the backbone, works pretty well for a lot of people. Methotrexate is another option. What else?
hydroxychloroquine has been tested, but it was a pilot study that seemed to work in reducing flares, but we never had any other trials. And it, at least in Europe, it was not used. So we don't really know what to say on hydroxychloroquine so far. To my knowledge, nothing is in preparation to test it. And then comes the biological therapy. And this is quite exciting because it's being more and more used now in those chronic settings. There are some developments that are focusing on CPPD that hopefully will bring in new treatments. But so far, we're using what's available. So probably the first one to have been tried out in the chronic setting was anakinra to target IL-1. The results were disappointing to say.
Hmm.
Some patients respond, but I think the majority don't. And over the past years,
Oh, sorry,
yeah,
that was anakinra for the chronic
yeah,
arthritis. I forgot to mention, what about anakinra for the acute arthritis? If for whatever reason you're unable to use colchicine and prednisone, is that an effective agent?
it is effective. It's really rare, honestly, to have refractory acute arthritis that you can't manage with conventional treatments. But in those rare cases, it seems to work. There was a trial that had been started in Switzerland that was opposed to steroids. Unfortunately, they had to stop the study because they had insufficient recruitment. But in the first few patients they had, anakinra was as efficient as triamcinolone to improve the pain. So it
Great.
does work in the acute setting, just like it does in gout.
Got it. But not
And
so well sort of in the chronic setting
yeah,
to prevent it.
especially when you
Interesting.
don't have inflammatory markers that are elevated, it seems that, yeah, in those cases, it doesn't.
Super interesting.
And so more recently came out the idea of targeting IL-6, which actually in the first study that was published in Nature in 2006 that showed the involvement of the NLRP3 inflammasome in crystal arthritis. Well, actually, we all remember it for gout, but CPPD was also tested in that study, and it showed that IL-6 also exploded in the inflammation caused by the crystals. And so tocilizumab was tried in case series. We now do it at least in France, quite commonly in refractory cases of chronic CPPD. We had a series of almost 60 patients last year presented at the ACR showing that it really did quite well. Not all patients responded, but many did, even those who were refractory to anakinra. We use it in France on a more routine basis, even if it's off-label. And we're starting a study as well, tocilizumab versus placebo, in the next month to test it formally and see if we could go further with that.
That is super interesting. And how easy is it to get tocilizumab approved for your patients in France who have chronic CPPD?
Well, in France, we have the chance of being quite free in what we choose for our patients, and every treatments are reimbursed by the National Social Security. The Social Security can raise an eyebrow when they're seeing some prescriptions. But basically, if we say, okay, we've got this scientific reference and we're experts in the area and we think it's a good idea, so they don't bother us. So that's quite easy for us to test it, and we are glad to be able to do that.
Amazing. And you mentioned these are, sort of older adults that have, chronic CPPD. How do you see the safety of tocilizumab in these patients?
Well, it's probably a bit less safe than it is in people with RA, for instance, who are usually, of course, younger. But globally, the safety was fine. And it was not huge safety issues that ended up the treatment. It was most commonly some neutropenia or more biological signals that said, okay, probably stop it in those patients. But it was just a bunch of patients who really had some infections, and it ended up actually better than you would expect in those more fragile older population.
Got it. And even though, it was efficacious, it sounds like it was good for about half the patients. Would you say that?
Probably even a bit more, and compare the first case series who had really typical CPPD disease, no questions asked about the diagnosis. In this larger population, it did include some patients who had more complicated diagnosis, and we know some phenotypes which are very, very hard to diagnose, and sometimes they're on the margin of the disease, particularly those sort of OA-like phenotypes with no biological inflammation, sometimes not that much evidence of CPPD on imaging. And it seems that it's these types of patients who are less responding to the treatments and probably lowering the numbers. But I expect in clinical trials where we'll be a bit more restrictive on being 100% sure that it's fully CPPD, I'm hoping that it's going to be a bit higher than that.
Great. Even, 50% is awesome as compared to like zero, right? Because in these chronic, like we don't have treatments for like very good treatments for this. So even if, half the patients got significantly better, that would be a huge advancement to the field. So that makes sense. I think colchicine, so do you have sort of in your mind a patient with chronic CPPD Do you have sort of an algorithm that you go to? First you try colchicine, and then where do you go? Do you do the methotrexate or do you do the tocilizumab?
Well, colchicine is the first step all the time. Methotrexate, it's usually in patients for whom I'm not so confident to going straight to the biological treatments, and particularly, as I said, in the phenotypes that are very RA-like, where I think it's worth trying it. And then currently, I'm tending towards trying actually tocilizumab first, even before anakinra. I'm feeling I have better results with it. So I'd say tocilizumab first. Surprisingly, we have the impression that the intravenous forms works better than the subcutaneous one. We have no clue why. That had been the first thing that had been seen in the first case series of 11 patients in Paris who had really great results. But they had, this surprising difference in subcutaneous and intravenous forms. And I must say, I have the same impression on the patients I treated afterwards. Some patients doing well intravenous, we put them on subcutaneous forms. They did not that well. And when we came back to the intravenous form, they did better. So, yeah, that's have no
A-
explanation there
And the dose of the intravenous I think you're using is 8 milligrams
per
per
month.
kilogram
Yeah,
once monthly.
yeah, exactly. That's the one.
Okay, so we have colchicine, maybe methotrexate, tocilizumab. Anything else that's sort of in the pipeline or anything else that's being tested for chronic CPPD?
Well, in the same vein, in some patients, we've tried sarilumab on the IL-6 receptor
Okay.
front. Sometimes it worked even in patients that were refractory to tocilizumab, surprisingly. And a few patients had canakinumab, but again, as you would expect, given the price, even us use it very rarely. There is, in the available drugs for other diseases, there is a trial currently ongoing in Italy on baricitinib. So hopefully may work out this way. Again, given the age of patients, there will be probably a limitation there. But that's what's in the pipeline there. And then there are, well, other drugs that are being developed. Some of them are being developed for gout, which should and could be useful for CPPD. I'm thinking particularly on the different LRP3 inflammasome inhibitors. One is more advanced in phase 3 in gout, and given the similar biological patterns of inflammation, it should and could work in CPPD as well if it works in gout. And there are other IL-1 inhibitors that are being developed, and CPPD could be the first indication in which they are developed. So we really hope that they will really broaden the scope of treatments that we could use.
Awesome. And Tristan, in thinking about sort of research, especially for people that are interested in getting into research and fellows, like what are the main questions in the field of CPPD that you think we need answered?
Well, pretty much everything. That's a bit the exciting part in CPPD. It's like you're sort of discovering medicine as you go. It's a bit surprising that such a frequent disease is so unknown yet. So pretty much everything. We have much to do in epidemiology. So far, we're just assuming that it's very frequent, but we're missing lots of diagnosis. When you're looking in the big databases, it's not well coded. So basically, the databases are missing it. So epidemiology, certainly there's a lot to do. We're just starting to look into the genetics, and we know how important it is to have some genetic basis on the knowledge of different diseases to find new therapeutic targets and just more understanding in the disease itself. So we're just starting, we're building cohorts right now to explore that. And of course, the treatments are a huge aspect to develop just because nothing's labeled so far, basically. And we're doing quite a lot of work on imaging, but I think it's probably the most advanced part in imaging, and particularly all the work that has been done on ultrasound, what we are doing on the different types of computed tomography. So probably the less abandoned part is imaging, probably. But we're advancing on all fronts at the same time, even on nomenclature. We are not talking the same language in CPPD yet, so we are trying to adjust on this as well. It may look stupid, but actually, when you're reading papers and when you're talking about chondrocalcinosis, to just talk about imaging or if you're talking about symptoms, it's really a different stuff. So yeah, we're doing that at the same time. So yeah, basically whatever is interesting you as a researcher, you can apply it to CPPD, and you'll probably be almost alone on that field.
Amazing. That's a great opportunity for people that are looking into research projects. Tristan, this has been really a masterclass in CPPD and especially in its management. I really appreciate your time in speaking with us today, and certainly all the work that you've done, the research that you've produced, and certainly everything that's going to come from now on, all those research studies that you mentioned. So thank you so much for your work and for your time here today.
You're welcome. It was great. Thanks.
CPPD has often been treated as the rheumatologic afterthought, a crystal disease that isn't gout, an arthritis that isn't quite like rheumatoid arthritis. But what Professor Pascart makes clear is that this is a frontier wide open for discovery, including genetics, imaging, inflammasome biology, and therapeutic innovations that are all just beginning to take shape. If you want to learn more, please listen to Dr. Pascart's presentation, Cracking the Crystal Code: Therapeutic Advances in CPPD, presented on Sunday, October 26 at 9:30 in Chicago in Convergence 2025. You can check it out live or find the recording from the ACR Convergence 2025 program on demand. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this and all other episodes at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app. Until next time, may your joints stay calm and your crystals cooperative. And of course, stay healthy. Here at ACR On Air, we'd like to take a moment to thank Pfizer, the sponsor of this podcast episode. Their dedication to research and collaboration with the ACR and the field of rheumatology has been essential to improving the lives of those impacted by rheumatic diseases. To find out more, visit Pfizer.com.